Great. So we're going to get started. Thank you, everyone, for coming to this summit, which is called Health Equity in Native America Summit. We chose that term very purposely because a lot of the conversations we're going to be having, or that we've already had on Monday, which was a great set and organization of speakers, which really hit on a lot of the key themes that we'll cover today also in different ways. The word summit really showcases a mandate for us to bring powerful institutions and community members together to have a formidable conversation about an important topic. And that is exactly what we have before us today at Task, which calls for the participation of people in power, institutions that are quite powerful, and people who are just who are community members who may not be part of these institutions but need a seat at the table. So Native American or health equity in Native America is a conversation that began in a very let's see if I can get there. We go. This started in a very kind of interesting way, and it leads into what is our statement of relationship. And I'm going to read that. I read it on Monday, and I'll read it again today for folks who may have not been with us on that day. So in 2021, I tweeted about a conversation that Harvard Chan School of Public Health had about health disparities in COVID. They had a diverse group of health experts discuss COVID and racial disenfranchisement. However, I was gravely concerned because the conversation didn't talk about how COVID caused more deaths per 100,000 people in Native America than in other racialized minority groups in the US. Dan Chande saw my tweet. So Dan is one of the organizers of the summit, saw my tweet and basically said, hey, let's do a conference to express the conditions for why Native America has suffered so badly, but also offers all of us a chance to understand how profoundly invisible governmental, academic, and medical institutions are making Native lives. So we decided to build a stage or a kind of a place of communion, if you will, for making Native lives matter in the world of social determinants of health, where health is often not defined in Indigenous terms. Indeed, it's in this moment at the beginning of this, or in the middle, or on the second day of this important summit, that I want to give a statement of where we are and where we should go. Our institutions, so the institutions that are hosting this summit are MIT, Harvard, Mass General Hospital, and Brigham and Women's, are on stolen Massachusetts land. They are on the sacred grounds and paths of several Indian nations, including the Wampanoag, the Nipmuc, and other nations. Our institutional tentacles, our institutional colonial extractive practices, if you will, extend into the Ojibwe and Dakota lands that were seized as part of the Morrill Act of 1862 and Morrill Act of 1890 and other hostile takeovers that funded MIT and other land-grant universities. Our university's investments in our creation of corporations have placed us in the middle of genocidal campaigns that extend from the railroads of the 1800s, for which bison were exterminated, for example, and perhaps we'll be talking about bison and foodways today, to the natural gas and oil pipelines today that MIT students design. The Nobel Peace Prize and the Nobel Prize in Economics were named for a man, Alfred Nobel, whose invention, dynamite, was used to decimate indigenous lands throughout the United States. American peace and fortune were born in the purposeful silencing of American Indian peoples. So, you know, this conversation, as you saw on Monday and as you'll see today, can go in various different directions. My question is, why does the U.S. have the highest rates of cannabis, opioid, and cocaine use in the world? Just kind of a random but not random question. We must be numb to survive a society that continually practices indigenous disappearance, a nation that can't say our names, American Indian, Native American, indigenous names, when it discusses disparities. The silencing of Native peoples affects everyone. It stymies education. It makes healthcare ineffective. It creates conditions of profiteering over environmental health. And we're here today, Wednesday, and we were here on Monday, to invite you all to invert this inhumanity, to focus medical education, medical business, and medical entrepreneurship on Native peoples and with Native peoples. To do that, as you will see, is to reinvent how we talk about everything from sports where racist mascots are used to economics of food to the ways that our news agencies report. And a question I often ask students and other faculty is, when is the last time you've seen an American Indian or Native American journalist on Good Morning America or World News Tonight or CNN or any other popular media outlet? When have we been faculty or deans or provosts at your universities? If we're there, not many of us exist. Let the presences of the Indigenous experts this week be permission, and today, be permission to prioritize Native lives and be led by Native peoples. I want to kind of state this also. This history is uncomfortable, but we need to take the resources that we have currently and move forward towards health equity. As I often say, not only must Natives be at the table is made from stolen Indigenous wood. This means the creation of opportunities for Native voices and identities to be present as we organize medicine and design clinical and non-clinical health spaces. So thank you for joining us for what is, I believe, the beginning of true health equity. So with that being said, I want to introduce you to what I've been here at MIT doing and sort of what Dan and I have been talking about on and off, and what Nicole, Dan, and Cameron and I have been talking about for a few months. I came to MIT. I was hired by MIT this past spring to come deal with a conversation that is very complicated. Essentially, we found out that MIT's third president, Francis Walker, who wrote a book called The Indian Question, which eventually in policy became the Indian Problem, which was used by various states such as New York, to deal with the fact that Francis Walker, was the third president of MIT, and that he basically, in no uncertain terms, really pushed for an economy of reservation, or an economy of Indian genocide and ethnic cleansing throughout the United States. One of the things that a lot of people don't realize is that he was one of the major voices in the creation of what we now call commodity food economics in Native America. So, we joke about commod bods or about fry bread bodies or things like that. Francis Walker helped design that process of turning the USDA and the federal government's Department of Interior more generally into kind of a streamlined injection of fake food and fake health into Native communities. So as you can see on these photographs, that was with AP Press that was passed around the United States in various outlets, and basically it was students and myself and leaders at MIT trying to come into relationship, which we really haven't been historically, coming into relationship to begin to both make Native lives matter at MIT, but also to rehistoricize and retell the story of the past of MIT in a way that will bring us into a better future. And this really gets into the conversation that we're having today. Healthcare and medicine is not healthy. As you can see on the screen, on the left is a recent Forbes article, and I believe that was from a couple weeks ago. And it says basically healthcare is trying to make itself future-proof because they're predicting that over 60, 70, maybe 75% of healthcare providers over the next decade or so will quit healthcare. And they're asking, what will it take for us to keep people in healthcare? As you can see on the right, I wrote an article several years ago, basically outlining the fact that there were people in healthcare that we never identified, most of whom were white. We never identified the fact that they were drugging themselves while practicing healthcare. Anesthesiologists, surgeons, nurses, the people who work in the ED across the board. So people who transport patients, people who are physicians and technicians, radiologists, in emergency departments. There was this epidemic of people that abused drugs who worked in healthcare, but there was also an epidemic of not talking about who they were. So you put these two stories side by side. If healthcare is losing people, and if the people who are there are enthralled in addiction, what does that mean? Healthcare and medicine is just not healthy. Now, Cameron showed gave us some data the other day, and I wanted to kind of reintegrate this into our conversation. Why, as healthcare and medicine is unhealthy, there's also this idea that Native people need healthcare to deal with disease states and states of in unequal health that grab our communities. So you're talking about, in this particular statistic, deaths before age 45. 25% of Native people, as opposed to the next highest level is 15% in African American Black communities. These are very difficult statistics. These are statistics about lack of access to healthcare. But my question, leading back to the article that I wrote and other journalistic sort of endeavors into healthcare, even if Native people have access to healthcare, is healthcare good for us? That's a big question, and I'm not going to answer it in this moment, but it's a question we should really consider. And he also provided sort of some statistics about who in healthcare is identified with what groups. And there's this idea that even if we get Native people into the pipeline of healthcare, right? Native people realize that we're not there and we're not supported fully in that space. And when we get there, when we're there being trained as doctors, nurses, physician assistants, there's this idea that we sort of want to kind of toe the line. We can't really buck and try to change healthcare because we're already not enough in terms of our numbers. And even with a dream and a vision, we really need the structure of healthcare, the entire community, to support our presence and allow us to really reinvent what medicine and healthcare is in the United States and worldwide, actually. But this reminds me of a recent debacle in the United States during the 2020 elections. CNN began to report who was exiting the polls. And all of us, so I'm from the Lumbee community of North Carolina, there's lots of us, we're tens of thousands of people. So, we're all about, yeah, we can push elections because we're so big. But when we started to read the data that news media was giving us, we realized that we're not even included as a category. CNN called us or fit us into a category called something else. Native people were shocked by this. We were totally flabbergasted. How can we, as Native people, the first people of this country, be deemed something else? We can't even be given a name or a category. And people have asked me over the last several months, I've lectured on this topic several times. They said, well, that's a colonial category, Native America. American Indian is a colonial term. And I asked them, I said, so let's say every term is colonial, everything from white to Latino to Asian, everything is a colonial term. Shouldn't we have a colonial term that identifies us? Shouldn't we be a category? So shouldn't, when people see that category, say, we're thinking about those people, and in this case, us, Native people. So again, something to grapple with. What does it mean to need us in healthcare, to need us more generally in American society when we're not even a category? So this leads to several things that I believe we will be talking about today. First is the need to create identity for Indigenous people. This is across the board. This isn't only in healthcare, but there's a need to do it in healthcare in such a way that it reverberates across society. There's a need to remove secrecy. I used to teach medical education in Chicago, and if you know Chicago historically and currently runs within the context of mafia community. There's a deep secrecy that defines life there. But as I was teaching medical students there, some of my students would actually say, "Why is it when we go to practice clinically? Why is it that when we go into Stroger Hospital, for example, why is it that we see like this idea, or not the idea, we see the reality that healthcare providers don't want to talk to each other, they don't trust one another, and literally everything comes down to documentation, because at the end of the day, nobody trusts one another." There's this idea that not that documentation isn't needed, it is, and it's legally needed, but there's this idea that when relationships are so scattered, they're so not existent, you have to wonder why. And in the context of medical school, medical education, and medicine as a professional practice, there's secrecy everywhere that really doesn't allow for the sharing of humanity, or for human relationships, which are typical of good human experiences. This leads into the third category of sort of what we're going to be talking about and what we need to consider: humanizing and trusting Indigenous people. One of the, I think it was a faculty member from Brigham and Women's the other day, I forgot who it was, stated that, why don't we have Native faculty? And Nicole, who's an organizer of this conference or the summit, and I often talk about, well, you have to get Native people in the pipeline to become faculty, right? But there's, how we get there to having the presence of Native people as faculty in medical education, but in education more generally in the United States, for me, comes down to institutionalization. what do institutions, which are oftentimes sitting on billions of dollars, what are they doing to very rapidly bring Native people into centers of power and center education around our identities, the way we think, and the fact that we own this land, we own everything. This is a colonized place that we own. That's an important conversation as we're kind of moving through today and post summit. The fourth category, the first space that we kind of idea or set of concepts that we need to consider is that health isn't a commodity. So I just brought up a while ago commodity foods or commod bods. There's an idea that the genocide of Native peoples historically in terms of food and in terms of medicine has been to turn our relationships with earth, turn our relationships with food into commodities, into things that mean that are only valued in dollars and cents. And part of our conversation, I believe, today will be about taking food out of a commodity, taking health out of a commodity, and bringing it back into the realm of the spiritual, into relationships, into this idea that food is part of our existence in the world that is not really understood by people who exist only in a colonial mindset. And then the fifth space or set of topics is the idea that we must place health in relationship to everything. And I want to kind of, this is a difficult conversation. What does it mean to have health, to place health in relationship to everything? I want to cover that or discuss that a bit here. One of the most difficult conversations in the United States is focused on, or is not focused on, the history of sterilization in the United States. From the early 1900s, it wasn't the 1950s and 60s, it was well before then, and I don't have time to get into that conversation. But since the beginning of the 1900s, medicine and the rise of contemporary medicine in the United States has been hinged or has been attached to the hip to experimental sterilization projects on indigenous people. Here is an example, an article that you can look up that is part of what they call JSTOR Daily. It says, the little known history of forced sterilization of Native American women. Jane Lawrence documents the forced sterilization of thousands of Native women by Indian Health Services in the 1960s and 70s, right? So we have Native people who now help lead Indian Health Services. And I think in the moment we're in, there's a restoration of relationship between Native people and Indian Health Services. But people, my age and perhaps even a bit younger, remember the horrible stories from Native people across the United States. Like, for example, when I would go to summer camp or something like that and hear Native people talking about how, their mothers and fathers and aunts and grandmothers and grandfathers were grossly mistreated by Indian Health Services. And we can't forget that history, but it must begin to frame how we look at the kind of, shall we say, kinship relationships between medicine and Native communities as we go forward. Just the other day, there was a very specific story that I was talking to students at University of Minnesota who are also researching their university's place in the history of Morrill Act land grants genocide. And they helped me understand that University of Minnesota often, basically in the early 20th century, wasn't really a school as much as it was a hub for both genocidal processes that were aimed at destroying Native lives, and subsequently, or at the same time, using those genocidal policies at University of Minnesota to really create medicine for everybody else. This gets into a whole interesting big story about how different companies, I believe General Mills is one of them, actually used the University of Minnesota to basically steal land and basically to create an economy of foodways and health that really was positioned and pointed at Native people, not for our good, but for our hurt. On that note, relationships between Native people and health go beyond the clinical space, beyond experiments in a clinical space, and to a larger conversation, a more expansive conversation that takes medicine beyond the clinical space into the environment. You can look up this video. I don't have time to show it to you now, but this is a video that was filmed for Mercy for Animals, where I joined several people in documenting the place of chicken CAFOs or corporate chicken farms in the Lumbee tribe of North Carolina. And what I'm realizing is that physicians in the Lumbee community are really, if I'm to be very honest, Lumbee physicians, Lumbee people who have, finished medical school, or other healthcare providers, nurses, PAs, have been placed in a position where they can't really push against what they're seeing: increased asthma rates, increased cancer rates. And oh, by the way, they're noticing that these rates are going up at the same time that the county that where Lumbee people live, which is called Robeson County, is being filled up with chicken CAFOs. These are not small farms. These are large, basically housing units that are like 3 times the size of a football field, oftentimes, that are filled with chickens that are grown very rapidly, genetically modified, filled with steroids, filled with antibiotics. And the waste from those chickens are poured into the water, they soak into the soil, and they're in the air for our children to breathe. And they create a lot of flies, which are very annoying and probably carry disease in ways that we don't understand. All right. So with that being said, I know that is heavy. I know that is perhaps mind altering in a way for some people who haven't been part of this conversation. But I believe that as we carry forth this conversation today, basically taking healthcare beyond the clinic a bit, just a little bit, into conversations that are outside typical medical conversations, we'll begin to really push forward and really open up what I consider to be a needed space politically, intellectually, and economically for Native people to exist in our full humanity. With that being said, I want to go over the schedule for today. We're going to have Pastor Miracle, who is Mohawk, speaking to us first. Warren Griffin and Janelle Pokowatchit from Native Lifelines, basically a space here in Boston for Native people to be cared for and treated with dignity and with humanity in ways that they can't be treated with that dignity and humanity in other places here in Boston. Ann Douglas, who has joined us last minute, but we are thankful that she has joined us as Director of Behavioral Health at Missoula Native Connections Project, is really an interesting, inspiring figure in her particular work. I'm not very familiar with it, but I am glad that she's joining us and really allowing us to take this conversation forward. Holly Pilson, she's an orthopedic surgeon. She's also a person who I've bowled with quite a bit over the years, and we continue to kind of antagonize each other because we think that we can beat each other in bowling. But no, we've been friends for many years, but she's in a position at Wake Forest Baptist Health that I think is critical in terms of teaching medicine, the medical community, how to mentor Native American people, but also how to train medicine, medical education, the medical enterprise, if you will, to invite themselves into relationship with Native peoples in a way that is empowering to Native communities and Native individuals. I'll be speaking after her, giving a lecture that really ties together my work at MIT and my research in health and Native identity and Native community. And then we're going to have Sean Sherman of Sous Chef, who I've heard a lot about him, never heard him in terms of recordings or anything. So a lot of people have contacted me and said, hey, the Sous Chef is going to be there. I'm like, yeah, don't know how we got them, but I'm excited that we did. And then we're going to have a representative of Natives, the North American Traditional Indigenous Food Systems, and I believe that's Dawn. We didn't put her name on there. I believe that's Dawn, who will be with us and will share with us the work that they do. And she kind of helps lead the Sous Chef organization also. So that'll be really exciting. Want to give a really brief shout out to our sponsors, MIT, especially the Office of the ICEO, which is the Diversity Office, Mass General Brigham, MGH, Mass General Brigham, Harvard University, Mass General Equity and Community Health, the Disparity Solutions Center, Native American Lifelines, and the People's Heart, which is what Dan Chande leads at Mass General Hospital.